Hi, my name is Heidi King, and I'm one of the PGY1 pharmacy residents at Emory University Hospital. Today I'll be presenting my research project entitled The Evaluation of Pharmacy-Driven Medication Access Initiatives in the Inpatient Setting. Our research team would like to disclose that we did receive the Adult Medicine PRN Seed Grant from ACCP to help fund our project. Transitions of care is defined as the movement of a patient from one care setting to another. This is often a place where medication errors occur and can lead to an increase in hospital readmission rates, as well as overall healthcare system costs. Specifically for our patients, we worry about them when they transition from the inpatient to the outpatient setting. They often have difficulty accessing medications due to lack of insurance, the need for prior authorizations, or high out-of-pocket costs. Pharmacists can play an essential role in this transitions of care process, given their clinical knowledge and expertise that allows them to complete prior authorizations or recommend cheaper alternative medications. The internal medicine pharmacists here at Emory University Hospital have taken an active role in the transitions of care process and have been intervening to help ensure patients are able to obtain their medications at discharge. The purpose of our project was to evaluate the impact of medication access interventions prior to discharge by pharmacy personnel. The primary outcome of our study is hospital length of stay. Secondary outcomes included a 7, 30, and 90-day all-cause and related readmission. We also looked at the transitions of care intervention in terms of what kind of intervention was being made, as well as the approval rate, the turnaround time, and cost savings. And we also looked at medication adherence. This was a retrospective cohort study. Patients were enrolled if they were admitted to Emory University Hospital from January 2014 to August 2020. All of our information was pulled from Data Warehouse and the Emory Electronic Medical Record. We included patients that were 18 years of age or older. They had to have evidence of a transitions of care note in their medical chart, and they had to have an inpatient or outpatient prescription for at least one high-cost or high-risk medication. This included things like our anticoagulants and antidiabetics. We excluded patients that were pregnant, that were located on non-medicine patient floors, or discharged from units like the ICU or the emergency department. There were 161 patients that met our inclusion criteria. Of that, we excluded 6 based on the fact that they were discharged from an ICU or a non-medicine floor, and we had 1 patient that transferred to Emory University Hospital Midtown. This left us with a total of 155 patients. Looking at the baseline characteristics of our patients, you'll see that it was pretty evenly split between males and females. Looking at race, most of the patients were either Caucasian or African American. The average age was 54. The average Charleston Comorbidity Index was around 3.3, and 87.7% of patients had some kind of prescription insurance. Our primary outcome was length of stay, with the average length of stay being around 9.1 days for these patients. We also looked at the readmission rate, and this readmission rate increased as time went on, with our 7-day readmission rate being around 5.8% compared to the 90-day that was 26.5%. We also looked at the types of interventions that were being made for these patients. Around 20.6% required a prior authorization. 12.3% involved pharmacists enrolling patients in a patient assistance program, and 29% involved giving patients coupons to help afford their medication. Of note, for all of the interventions that required a prior authorization, they were all approved. We also looked at the 7-day fill history for these patients. Through the electronic medical record, we were able to look at an external fill history for patients to see if they actually picked up that medication within 7 days of being discharged, and we found that that occurred in around 63.5% of patients. There were 152 patients that had the copay of their medication documented. Of those, you'll notice that 68.4% had a copay of less than $10 after the pharmacist intervened to help them afford their medication. We also looked at the time spent by pharmacy personnel on these interventions. There were 89 patients that had this documented in their chart, and you'll notice that the majority of the interventions took pharmacy personnel between 30 minutes to 1 hour. We also looked at the type of medication classes that pharmacists were intervening on. Majority were done on anticoagulants, specifically things like our DOACs that are more expensive and often require patients to use a coupon or be enrolled in some sort of patient assistance program. Then we had antibiotics, so things like our oral vancomycin, followed by our anti-diabetics, and this was generally insulin, both short and long acting. Then antivirals, antifungals, and then in our other group, this included an anti-epileptic, a pain reliever, and a phosphate binder. Overall, we were able to see that pharmacists are able to assist in a variety of different transitions of care interventions and impact the outcomes for these patients. Moving forward, we hope to include a control group that aims to further evaluate and demonstrate the impact that pharmacists can make on transitions of care. The objective of this presentation was to describe the impact of inpatient, pharmacist-driven transitions of care services on clinical outcomes. My self-assessment question is, what impact did pharmacist-driven transitions of care initiatives have on hospital length of stay? And according to our study, the length of stay for these patients was around 9.1 days.